Hey, welcome back to the deep dive. Okay, imagine this. You're sitting down for, I don't know, what feels like the simplest meal, maybe a warm slice of bread or a bowl of pasta.
Yeah, comfort food.
For most of us, that's just food, delicious everyday stuff. But get this, for a surprising number of people, that seemingly harmless bite can actually kick off this profound systemic immune response.
Sends our whole body into a kind of hidden battle.
It really does. So today, we're doing a deep dive into your sources on a condition often misunderstood as just, gluten sensitivity.
Celiac brew. Or celiac disease, as most people know it.
Right. And our mission here is to really pull back the curtain, unpack what this complex, chronic immune-mediated disorder truly is, why it happens.
It's incredibly varied symptoms, which is key.
Yeah, how it's diagnosed, definitively diagnosed, and, well, what life actually looks like for people dealing with it. We've sifted through a stack of research for you.
Giving you the essentials, the shortcut to being properly clued up.
We're going to explore that really intricate dance between genes, diet, and the immune system, moving beyond just the surface stuff.
Absolutely. To really grasp its significance, it's fascinating because the material makes it clear this goes way beyond just a dodgy stomach.
Okay, let's nail down a definition first. From the research, celiac disease is a chronic, immune-mediated, systemic disorder.
Systemic is the key word there. Impacts the whole body.
Triggered by eating gluten, but only in people who are genetically susceptible. And this whole thing leads to inflammation, damage in the small intestine.
Right, the lining gets damaged, which causes malabsorption, so you can't get your nutrients properly.
And then that wide range of symptoms, potentially anywhere in the body.
Exactly. And the trigger, as you said, is dietary gluten, which isn't just one single thing, is it?
No, the sources break it down. Gluten is a complex protein group. The main ones to know are gliadin in wheat,
Hordein in barley,
and secalin in rye. So wheat, barley, rye. Those are the big three.
But here's something really interesting, a crucial point often missed. Oats. Technically, oats themselves, they're safe.
Oh, really? I thought oats were out too.
Well, inherently, they're okay. But the problem, and the data backs this up strongly, is cross-contamination. They're almost always processed in the same places as wheat, barley, or rye.
Ah, okay. So the oat itself isn't the enemy, but it hangs out with the wrong crowd, basically.
Pretty much. So that cross-contamination risk is huge. That's a really vital clarification.
Definitely. Now, you mentioned genetically susceptible individuals. Let's talk about that genetic blueprint. What does it look like?
It's a strong link. Over 90% of people with celiac have a specific gene marker, HLA-DQ2.
90%, wow.
And most of the others have a similar one, HLA-DQ8. But, and this was a real aha moment in the research, for me, these genes are necessary, but they're not sufficient.
Meaning?
Meaning you need the gene to potentially get celiac disease, but having the gene doesn't guarantee you'll get it. Something like 30–40% of the general population actually carries these genes.
30 to 40%, but only about 1% actually develop celiac disease.
Exactly. So it tells you there have to be other factors involved. It's not just your DNA. That's a massive insight, a real game changer for understanding risk.
Okay, so you need the gene, but something else has to happen. Let's trace that something else. The sources call it the celiac cascade, the step-by-step immune reaction. It starts with eating gluten, right?
Correct. You eat gluten, and your gut doesn't fully digest it. It leaves behind these problematic protein fragments, peptides, rich in proline and glutamine.
Like that 33-mer gliadin peptide mentioned in the research?
That's the famous one, yeah. It's really resistant to breakdown. Then, in people who are predisposed, these peptides manage to sneak across the gut lining.
The intestinal barrier. So increased permeability, like a leaky gut, is part of it.
Seems to be, yes. And once they're across, this key enzyme called tissue transglutaminase, or TTG, gets involved.
PTG, what does that do?
Think of TTG as modifying those gluten fragments. It changes them, slightly deamidates them is the technical term. This change dramatically increases how strongly they bind to those HLA, DQ2, or DQ8 molecules on immune cells.
So TTG basically flag the gluten peptides, making them super visible and sticky for the immune system if you have those genes.
You got it. It's like putting a big red flag on them that the immune system, specifically the T cells, can now easily recognize.
And that's when the real immune system fireworks begin. What happens when those T cells get activated?
Exactly. Those activated T cells kick off a strong inflammatory response, what the sources call a Th1-mediated response. It's like an aggressive attack.
Okay.
They release inflammatory signals like interferon gamma, and they wake up other immune cells, including B cells. And those activated B cells, they start churning out antibodies.
Antibodies against the gluten.
Against the gluten peptides, yes, but also, crucially, against the body's own TTG enzyme. These are the autoantibodies we look for in blood tests, anti-TTG.
Right. Okay. So the immune system attacks the gluten and the enzyme that modified it. And the end result of all this inflammation in the gut.
It leads to damage. You get crypt hyperplasia, the sort of valleys in the gut lining overgrow. You get more immune cells, called intraepithelial lymphocytes, crowding into the gut lining. And the hallmark, the classic sign.
Villus atrophy.
Villus atrophy. That's the flattening or destruction of the villi, those tiny finger-like projections lining the small intestine that are absolutely essential for absorbing nutrients.
Wow. It's pretty amazing how one protein can set off such a complex chain reaction. But like you said, understanding the mechanism is one thing. How does this actually show up in people? Why is it so variable and often missed?
That's the million-dollar question, isn't it? The research hammers this home. The presentation is incredibly variable, which makes diagnosis really tough.
So the classical picture we might have.
Usually seen in babies or young kids after gluten's introduced, that's when you often get the obvious gut symptoms tied to malabsorption.
Like chronic diarrhea, swollen belly, kids not growing properly.
Weight loss, vomiting, maybe just being really irritable. Yeah, those are clearer signals.
But that's not the most common way it presents anymore, especially in adults.
No, what's called non-classical or atypical celiac is much more common now, particularly in older kids and adults. And the kicker is gut symptoms might be really mild or even completely absent.
Really? No gut symptoms at all?
Can happen. Instead, the main problems might be totally unexpected, affecting other parts of the body.
Okay, so what kind of unexpected signs are we talking about?
Well, the single most common extraintestinal sign, according to the sources, is iron deficiency anemia that doctors can't otherwise explain.
Just low iron.
Huh.
Yeah. Or maybe chronic fatigue, just feeling wiped out all the time.
Yeah.
Weakness, osteopenia or osteoporosis, weak bones, because you're not absorbing vitamin D and calcium properly.
Even if you're eating enough calcium.
Even then, yeah. In younger people, maybe short stature or delayed puberty. And then there's that really specific skin condition.
Dermatitis herpetiformis. That's the one.
Yeah.
An intensely itchy, blistering rash, often on elbows, knees, buttocks, sometimes called celiac disease of the skin, really points to that systemic nature.
Wow. What else?
You might see slightly abnormal liver function tests. Neurological issues like peripheral neuropathy, tingling, or numbness in hands and feet, or ataxia, which affects balance, sometimes called gluten ataxia.
Gluten ataxia. Never heard of that.
It's a recognized thing. Also, reproductive problems, unexplained infertility, recurrent miscarriages, even just getting lots of mouth ulcers, those aphthous ulcers or canker sores.
Okay, so the range is huge. What about silent celiac? What's that?
Silent celiac is when someone has zero symptoms, they feel fine, but their blood tests are positive, and if you do a biopsy, you find the villus atrophy, the gut damage.
So the damage is there, but the person doesn't feel it. How do they find that?
Often discovered accidentally, maybe during screening of high-risk groups like family members of someone with celiac.
Wild. In potential or latent celiac.
That's someone with a genetic risk, positive blood tests maybe, but their biopsy is normal. For now. They don't have the villus atrophy yet, but they might develop it. And symptoms, later on, it can evolve.
Right. And finally, there's refractory celiac disease. You said it's rare.
Less than 5% of cases, but serious. These are people whose symptoms and gut damage don't improve even after being on a strict gluten-free diet for over a year.
That sounds incredibly frustrating and difficult.
It is, and it needs careful management, specialist care, because there's an increased risk of complications like lymphoma.
Okay, so given this huge variability, how do doctors actually pin down a diagnosis?
It's a multi-step process, and the sources are crystal clear on one thing. You must do the testing before the person starts a gluten-free diet.
Why is that so critical?
Because if you cut out gluten, the gut can start to heal and the antibodies in the blood can decrease. Your tests might come back negative even if you actually have celiac disease. It hides the evidence.
Okay, crucial point. So step one is usually blood tests, the serology.
Yes, initial screening. The go-to test is the IgA anti-tissue transglutaminase antibody, IgA-TTG. It's highly sensitive and specific.
Over 90%.
Yeah, pretty good. Another option is the IgA endomycyl antibody, IgA-EMA. Super specific, almost 100%, but maybe more costly and trickier to run.
And you mentioned something vital about IgA levels generally.
Yes, you have to measure the person's total serum IgA level at the same time, because maybe 2–3% of celiac patients also have selective IgA deficiency.
Meaning they just don't make much IgA antibody.
Exactly. So if you only test for IgA-based celiac antibodies like IgA-TTG or EMA, the test will be falsely negative. They can't make the antibody you're looking for.
Ah, so in those cases.
You have to use IgG-based tests instead, like IgG-TTG or IgG-DGP, catches those cases. And worth noting, the old anti-gliadin antibody tests. Not recommended anymore, not specific enough.
Okay, so blood tests first, checking total IgA if those are suggestive. What's next? The biopsy.
Yes, the small intestinal biopsy is still considered the gold standard for confirming the diagnosis.
Done via an endoscopy, right? A scope test.
Correct, an EGD. And it's important to take multiple samples, the guidelines say at least 4, from the duodenum, including the duodenal bulb, because the damage can be patchy.
Right, you don't want to miss it. And what are they looking for under the microscope?
Those histological changes, often graded using the Marsh classification. Marsh 1 is just increased immune cells in the lining. Marsh 2 adds crypt hyperplasia. And Marsh 3 is the classic finding.
Villus atrophy again. The flattened villi.
Yes, graded as partial, subtotal, or total flattening. Marsh 3 is generally diagnostic.
Okay. What about the genetic testing for HLA-DQ2 and DQ8? Is that routine?
Not usually for initial diagnosis if the blood tests and biopsy are clear. It's more of an optional tool in specific situations.
Like when?
Its main power is in ruling out celiac disease. If you test negative for both DQ2 and DQ8, it's extremely unlikely you have celiac. It's a great rule-out test. It's also useful, say, if someone already started a gluten-free diet before getting diagnosed, making the other tests unreliable, or for screening close family members to see if they carry the risk genes.
Makes sense. And the final piece of the puzzle is seeing how someone responds to treatment.
Exactly. Step 4 is seeing clinical improvement symptoms getting better and serological improvement, those antibody levels dropping once they're on a strict gluten-free diet. It supports the diagnosis.
Which brings us to management. The sources are pretty clear. The only treatment is
a strict, lifelong gluten-free diet, no ifs, ands, or buts.
Lifelong. That sounds like a huge adjustment. What's allowed, what's out?
Allowed are naturally gluten-free foods. Things like rice, corn, quinoa, buckwheat, plain meat, fish, eggs, dairy, fruits, veggies, nuts.
And out is anything with wheat, barley, rye, or their derivatives.
Correct. And this is where patient education becomes absolutely critical. It's not just about avoiding bread and pasta.
You mean hidden gluten?
Exactly. Learning to read food labels like a hawk, understanding cross-contamination risks like using the same toaster or cutting board, and finding hidden gluten in things you wouldn't expect.
Like what? Sauces, soups?
Sauces, soups, gravies, marinades, processed meats, some candies, even medications, supplements, sometimes lip balm or cosmetics. It requires constant vigilance.
Wow, that sounds less like a diet and more like detective work, full time.
It really is. It's a steep learning curve, and support is vital. And because of the past malabsorption, nutritional support is key too.
Right, correcting those deficiencies you mentioned, iron, folate, B12, vitamin D, calcium.
Yes, supplementation is often needed initially, and ongoing monitoring is crucial.
How do they monitor?
Regular check-ins to see if symptoms have resolved. Repeating the antibody tests like TTG because the levels should fall and ideally normalize if the diet is being followed properly. It's a good marker for adherence.
Okay.
Plus, monitoring nutritional status, checking bone density periodically.
Do they need repeat biopsies regularly?
Not usually, no. Only if someone isn't improving as expected, or if new worrying symptoms pop up, or maybe sometimes to confirm the diagnosis if it was initially uncertain.
And for those rare refractory cases?
That requires specialist care. Double-checking diet adherence is step 1, but often immunosuppressive medications might be needed.
Okay. Now let's talk about why sticking to this diet is so critical. What happens if celiac disease goes untreated or someone doesn't manage the diet well? The complications. This is where the seriousness really hits home, doesn't it?
It really does. This underlines why diagnosis and strict adherence are non-negotiable. The long-term risks are significant.
Beyond just the immediate gut issues and deficiencies.
Yes, you've got the malabsorption leading to severe malnutrition, ongoing vitamin deficiencies, but also neurological problems we touched on, neuropathy, ataxia, even seizures in some cases.
And the bone health.
Big impact there. Osteoporosis, increased risk of fractures because of that poor calcium and vitamin D absorption. Reproductive problems too, infertility, issues during pregnancy.
And the most serious risks.
The increased risk of certain cancers. The research highlights enteropathy-associated T-cell lymphoma, or EATL. It's rare but aggressive. Also, small intestinal adenocarcinoma and some cancers of the throat and esophagus.
That's sobering. Really underscores it's not just a digestive issue.
Absolutely not. Plus, having celiac increases your risk of developing other autoimmune disorders. Things like type 1 diabetes, autoimmune thyroid disease like Hashimoto's. They often travel together.
It's like a gateway to other immune problems if not managed. So, given these links, screening makes sense in certain groups.
Definitely. The sources recommend screening first-degree relatives, parents, siblings, children of someone with celiac because their risk is much higher, around 10%.
Oh, else?
People with those associated autoimmune conditions, type 1 diabetes, autoimmune thyroid or liver disease, Sjogren's syndrome, also individuals with certain genetic syndromes like Down syndrome, Turner syndrome, Williams syndrome.
And people with that IgA deficiency we talked about earlier.
Yes, they should be screened too, using the IgG tests.
It's a complex web. And just briefly, what other conditions might look like celiac, causing confusion? The differential diagnosis.
Good point. Several things can mimic it or cause similar gut damage. Crohn's disease, for example. Tropical sprue, bacterial overgrowth in the small intestine, simple lactose intolerance, other autoimmune gut disorders.
Even medications.
Yes, certain drugs, like the blood pressure medication olmesartan, have been linked to celiac-like gut changes. So it highlights why that careful diagnostic process blood test biopsy is essential to get the right diagnosis.
And we absolutely need to clarify non-celiac gluten sensitivity, NCGS. How is it different?
Crucial distinction. People with NCGS get symptoms gut pain, fatigue, brain fog after eating gluten, similar to celiac. But here's the key. They don't have the positive antibody tests, like anti-TTG, and they don't have the villus atrophy, the intestinal damage seen in celiac disease.
So similar symptoms, but no autoimmune attack or gut damage.
Exactly. NCGS is considered a diagnosis of exclusion, meaning you rule out celiac disease, wheat allergy, and other causes first. It doesn't carry the same long-term risks like malignancy or nutrient deficiencies associated with celiac.
Okay, that's a really important difference to understand.
Yeah.
Wow. So we've really journeyed through celiac sprue today, from just, a piece of bread to the genetics, the microscopic immune battle, that bewildering variety of symptoms, and the very specific steps for diagnosis and lifelong management.
It really shows how something seemingly simple, a dietary protein, can trigger such a complex body-wide health issue. Highlights how interconnected everything is.
It absolutely does. A powerful reminder of the body's intricate workings.
And how much we're still learning about that delicate balance.
So here's something to think about. Knowing the profound, often hidden impacts that a protein like gluten can have, how might understanding this kind of complex immune response change the way you think about maybe seemingly minor dietary choices? Not just for celiac, but for overall wellness and maybe the importance of really truly listening to your body.